Picture this scenario for a second. You've done all the research, you've saved up the money, and you finally booked this cutting-edge regenerative medical procedure.
Right.
You are getting the O shot, so you go into the clinic, everything goes smoothly, and you head home feeling super optimistic about the results. But, later that afternoon, the stress of the day kind of catches up with you. You feel this dull headache coming on. And without even thinking twice, you just reach into your medicine cabinet, pop a common over-the-counter pill like maybe an Advil or an Aleve, swallow it down with a glass of water, and move on with your day.
I mean, for most of us, grabbing an ibuprofen for a headache is just an automatic reflex. We don't
Yeah.
even log it in our brains as taking medication.
Right, exactly. But by swallowing that single, completely normal pill, you might have literally just sabotaged the entire procedure you paid for.
Oh,
You
absolutely.
might have shut down the exact biological process the O shot relies on to work at all. So, welcome to today's deep dive. We are investigating a really specific, but honestly incredibly consequential question.
Yeah, this is a big one.
What is the required withholding period for non-steroidal anti-inflammatory drugs? So NSAIDs like ibuprofen and aspirin, how long do you need to avoid them prior to and following an O shot appointment?
And we aren't just going to, hand you a dry list of rules today. The goal is to really understand the underlying biology. Because once you grasp exactly why the timing of these everyday medications is so critical to the success of a regenerative procedure,
It all clicks.
right, the seemingly strict clinic guidelines will actually make complete sense.
So to get to the bottom of this, we are synthesizing clinical instructions from multiple medical spas and regenerative practices all across the country. We're looking at clinics like Genesis Lifestyle Medicine, RegenX, Rejuvenation,
And
MD.
yeah, really good cross-section.
And we are pairing those clinic handouts with hard, peer-reviewed research. So we have studies from the Uniform Services University and the American Journal of Sports Medicine. Our mission today is to just give you a definitive, science-backed guide to basically protecting your investment in this procedure.
Well, and when you look at the source material from those various clinics, you quickly realize the guidelines handed to patients can vary wildly.
Oh, they're all over the map.
Seriously, one clinic might tell you to stop taking pain relievers for 5 days before your appointment. Another says 2 full weeks.
Right?
And some even say one specific over-the-counter pill is perfectly safe, while the actual laboratory data suggests the exact opposite.
Which is wild. So
Yeah.
to navigate that whole maze of conflicting information, we kind of have to start at the very beginning. Before we can understand why an NSAI ruins the O shot, we need to establish what the O shot actually relies on to work in the first place.
I have to lay the foundation.
Exactly. For those who might be newer to the specifics, the O shot is a non-surgical procedure designed primarily to increase female sexual arousal, improve natural lubrication, and treat issues like urinary incontinence. And the engine driving all of those benefits is PRP.
Right. Platelet-rich plasma. That is basically the biological foundation of this entire field of regenerative medicine.
And the process itself is, relatively straightforward on the patient's end. You go in, they draw a small amount of your own blood, and they put that blood into a centrifuge. It spins at a super high speed to separate the components, and it isolates this concentrated layer of plasma that is just packed with your body's own platelets. Then they take that concentrated PRP and inject it into highly specific areas of the vagina and clitoris.
Which sounds intense, but it's very targeted.
Right. I always like to picture this whole PRP process like a major construction site. So when you get the injection, the platelets are basically the foremen arriving at the site. They don't really do the heavy lifting themselves.
They're the managers.
Right. Instead, they show up with the blueprints, they start blowing their whistles, and they signal the local stem cells to come in and actually build the new tissue.
I love that. The construction analogy works beautifully for the initial concept, but let's actually look at what those blueprints actually are in biological terms, because this is really where the magic happens.
Okay, let's hear it.
When these concentrated platelets are activated in your tissue, they begin to release a massive cascade of specific growth factors.
Yeah, I noticed the clinical research in our sources kept throwing around these acronyms for the growth factors, things like VEGF, PDGF-AB, and TGF-B1.
Right.
And honestly, as a patient, seeing a wall of acronyms can be a bit intimidating. What do those actually do?
They are highly specialized signaling proteins, and their names basically tell you exactly what they do. Let's take VEGF, for example. That stands for vascular endothelial growth factor.
Sure.
Its specific job is to stimulate angiogenesis, which is just a fancy word for the creation of brand new blood vessels.
Wow, okay.
So in the context of the O shot, more blood vessels mean dramatically increased blood flow and sensitivity to the area.
So it's literally building new physical infrastructure.
Exactly.
What about the others, like the PDGF?
So PDGF stands for platelet-derived growth factor. That one is essentially responsible for triggering cell division and pulling fibroblasts into the area.
Fibroblasts.
Yeah, they're the cells that synthesize the extracellular matrix. And then you have TGF-B1 transforming growth factor beta-1, which is crucial for stimulating collagen production and repairing the actual muscular tone of the pelvic floor.
Got it.
So once they're introduced, these proteins literally wake up the dormant stem cells in the pelvic region and put them to work generating healthier, much more functional tissue.
Okay, so for those platelets to be able to release all those growth factors, they require a really specific, naturally occurring biological cascade to trigger them.
Right.
Right. Like they don't just act automatically the second they are injected.
No, they don't.
That entire activation process is basically entirely dependent on platelet aggregation, which just means the platelets clumping together, and a localized controlled inflammatory response.
Which is the core tension of our whole deep dive today.
Exactly.
The O shot fundamentally relies on platelet aggregation and inflammation. So we have to look at what happens when we introduce a drug designed specifically to stop inflammation into that exact environment.
Right, which brings us to NSAIDs, non-steroidal anti-inflammatory drugs. These are arguably the most common class of medication in the entire world.
Everyone has them in their house.
Right. We are talking about aspirin, ibuprofen, which you might know as Advil, or Motrin naproxen, which is Aleve, and even prescription ones like meloxicam. So how exactly do these totally ubiquitous pills shut down such a sophisticated cellular regeneration treatment?
Well, it all comes down to enzymes.
Makes
NSAIDs function by blocking specific enzymes in your body called KOX enzymes. That's cyclooxygenase.
Got it.
And there are two main types you need to know here, KOX1 and KOX2.
Mm-hmm.
Under normal circumstances, KOX1 is sort of your baseline housekeeping enzyme.
Right, it's just keeping things running.
Yeah, it protects your stomach lining, and crucially for our discussion, it produces a chemical called thromboxane. Thromboxane is what makes your platelets sticky so they can actually aggregate.
Oh, I see. And then COX2 is like the emergency response enzyme.
Correct. KOX2 ramps up production when they're in tissue damage. It produces prostaglandins, which are the lipid compounds that cause the intense inflammation, pain, and fever.
Right.
So when you have a headache or like a swollen ankle, taking an ibuprofen blocks both KOX1 and KOX2. The pain and swelling go down, which obviously feels great. But in the context of PRP, blocking those enzymes essentially paralyzes the platelets.
Because you are turning off their stickiness?
Exactly.
If they can't clump together, they can't activate. And if they can't activate, they just hold on to all those vital growth factors instead of releasing them into your tissue.
You are actively suppressing the very early inflammatory signals that the stem cells need to guide the tissue repair.
See, I am genuinely stuck on one thing here, though.
What's that?
It just feels like a massive contradiction to everything we are taught about health. Like, we spend our whole lives trying to stop inflammation, you know? We ice our sprained ankles immediately. We take these pills specifically to stop swelling. So why are we paying a clinic thousands of dollars to trigger the exact thing I usually try to cure?
It is a totally valid question, but it stems from a fundamental misunderstanding of how the human body repairs itself. We really have to distinguish between chronic inflammation and acute inflammation.
Okay, break that down.
Chronic inflammation, where your body is in this constant low-grade state of alarm for months or years due to stress or poor diet,
Yeah.
that is absolutely detrimental to your health.
Right, that's the bad stuff.
But acute inflammation, that is the mandatory first step in the healing cascade.
So acute inflammation is actually the vehicle for the cure, not the disease itself.
Precisely. When you receive a targeted microinjury through a PRP injection, acute inflammation is the signal fire.
Oh, I like that.
Yeah. The initial swelling brings increased blood flow, which carries white blood cells and nutrients. It basically tells your immune system, hey, we need resources over here immediately.
Right.
By taking an NSAID, you are effectively dumping a bucket of water on that signal fire. You are chemically telling your body that everything is totally fine, so it doesn't bother sending the stem cells and healing resources to the area.
Wow. You literally need the fire alarm to ring so the fire trucks actually show up.
That's a great way to put it.
And the data backs this up beautifully, too. We looked at a 2014 study published in the Journal of Orthopedic Research. They tested what happens to PRP when the donor blood is pretreated with NSAIDs.
And what did they find?
The results were stark. They confirmed a statistically significant drop in the release of those growth factors we talked about earlier.
Yeah, that makes perfect sense. But we also have to make a really vital distinction here between the different types of NSAIDs because they interact with those COX enzymes very differently.
Right, not all pain relievers are created equal.
Exactly. There is a massive biological difference between aspirin and drugs like ibuprofen, and that difference entirely dictates the withholding timeline.
Let's explore that difference then. Ibuprofen and naproxen are what researchers call reversible COX inhibitors.
Reversible being the key word there. That means they bind to the enzyme and block it, but eventually as the drug metabolizes and leaves your system through your liver and kidneys, the enzyme's function returns to normal.
Okay.
So the disruptive effect is largely dictated by the drug's half-life in your bloodstream.
But aspirin is an entirely different beast.
It really is.
Aspirin is an irreversible COX-1 inhibitor.
Yes. When aspirin binds to a platelet, it permanently inactivates that specific platelet for its entire lifespan. It chemically alters the enzyme in a way that just cannot be undone.
That's crazy. So you aren't just waiting for the aspirin to flush out of your system. You literally have to wait for those disabled platelets to die off?
Yep.
How long is the lifespan of a platelet?
It's about 7 to 10 days. So if you take a single baby aspirin for heart health, every single platelet that was in your circulation at that moment is permanently incapable of releasing its full payload of growth factors.
Wow.
Your bone marrow basically has to manufacture an entirely new batch of fresh platelets before your blood can function optimally for a PRP treatment again.
Okay, so if aspirin completely ruins the platelets for 10 whole days and ibuprofen pauses them based on its half-life, when do I actually need to empty out my medicine cabinet before an O-shot appointment?
Well, that's the big question.
Right. This brings us to the core mission of our deep dive, the withholding timeline. When you look at the sources, the clinic guidelines are just all over the map.
They are. If you look strictly at the pharmacological half-life of the drugs like the absolute minimums, some clinical guidelines suggest you only need 48 to 72 hours for ibuprofen to clear out and 7 to 10 days for aspirin to allow for the new platelets.
But the clinical consensus from the medical spas and practices we reviewed leans much, much more conservative than just the bare minimum half-life.
Definitely.
Most of the clinics like Dermatouch RN and Genesis Lifestyle Medicine strongly advise avoiding all NSAIDs for 1 to 2 weeks prior to the procedure.
Right.
And we uncovered this fascinating piece of research evaluating naproxen that actually explains why this longer washout period is necessary. It noted that a 1-week washout isn't just about the drug leaving the blood because, the drug is completely undetectable in like 3 to 4 days.
It flushes out pretty quick.
Right. So the extra time is required to allow targeted prostaglandins to completely replenish at the actual tissue level.
And that's the key. It's not just about whether the chemical is gone. It's about whether your physical tissue has recovered its full capacity to mount that necessary inflammatory response.
Yeah.
You literally have to rebuild the biological environment.
So that's before the shot. But the post-procedure rules are just as critical, right?
Absolutely.
You've just had the injection, and you need those localized platelets to do their job without interruption. So again, most clinics recommend avoiding NSAIDs for 1 to 2 weeks after the shot. But we found one source, the Specialist Clinic out of San Jose, that pushes this even further. They recommend avoiding NSAIDs for up to 6 weeks for optimal results.
6 weeks is a long time.
Right. But they base this on an animal study by Salk et al., which clearly demonstrated that NSAID use even weeks after a biologic injection significantly impaired the long-term regenerative outcomes.
Well, it makes sense because tissue regeneration isn't an overnight event. Those stem cells are actively working, building new vascular networks, laying down collagen, and they are doing this over the course of several weeks.
Right.
So if you introduce a powerful systemic anti-inflammatory drug into the body a week or two into that process, you are still going to disrupt the ongoing cellular communication.
Okay, so if I'm a patient listening to this and I'm trying to prepare for my O-shot and I see one clinic handout saying 5 days, my doctor says 1 week, and a research paper suggests 6 weeks, what is the practical takeaway here?
Right, you need a bottom line.
Yeah. What is the golden rule I should follow to protect my financial and physical investment in this procedure?
Synthesizing all the clinical data and aiming for the safest, most efficacious route, the consensus golden rule is this. Aim for a full 14 days before and 14 days after.
2 weeks on either side.
Exactly. The research indicates that platelets are actively releasing the bulk of their growth factors for about 2 weeks post-injection. So by keeping your system entirely clear of KOX inhibitors during this 28-day window, you basically ensure the initial signaling cascade is completely unhindered.
2 weeks before, 2 weeks after. That gives the procedure the absolute maximum chance to work.
Exactly.
But, a month is a really long time to go without any pain relief.
It really is.
People get headaches, people get menstrual cramps, and getting an injection in a highly sensitive area can definitely cause some post-procedure swelling and discomfort.
For sure.
So what can a patient safely take during that month-long NSAID ban? This leads us into a massive contradiction in our source material, something we are kind of calling the Tylenol paradox.
Yeah, the clash between standard clinical practice and laboratory science on this specific issue is just fascinating.
It really is. Almost every single medical spa guideline we looked at, from clinics in New York City to Beverly Hills to Vermont, they offer the exact same standard advice for managing pain. They tell patients do not take NSAIDs like Advil or Aleve, but you can take acetaminophen, which is Tylenol, for pain relief.
Right.
They present it to patients as this totally safe, non-inflammatory alternative.
And historically that makes sense because acetaminophen is not classified as an NSAID.
Oh, really?
Yeah. Its mechanism of action is primarily located centrally in the brain to reduce pain and fever rather than out peripherally in the tissues, reducing inflammation like an ibuprofen does.
I didn't know that.
Yeah, so because it doesn't aggressively block KOX1 and KOX2 in the peripheral tissues, the assumption has basically always been that it shouldn't interfere with the peripheral inflammation required by the PRP.
But then we actually dug into the scientific literature provided in our sources, and we found 2 major peer-reviewed studies that completely dismantle this blanket safety net.
Yeah, they really do.
A 2014 study from the Uniformed Services University took human blood samples and exposed them to acetaminophen. They found that acetaminophen actually did inhibit platelet aggregation.
Oh.
And it didn't even take a massive dose. It started inhibiting aggregation at the standard 1x dose, dropping collagen-stimulated aggregation down to 78% of the control group.
See, that is a statistically significant suppression of the very mechanism you are literally paying thousands of dollars to utilize.
Exactly. And we also have a more recent 2022 systematic review by Kao et al. Evaluating common medications and platelet function. Their conclusion states outright that acetaminophen should be considered for suspension before a PRP injection due to its potential to diminish treatment effects.
It's right there in the data.
But wait, if Tylenol acts centrally in the brain and doesn't block the COX enzymes in the tissue like ibuprofen does, how is it chemically shutting down platelets in a laboratory blood sample?
That's a great question. The biochemical mechanism behind acetaminophen is actually still an active area of research, but the leading understanding explains exactly why we see this suppression.
Okay.
Acetaminophen doesn't block the active site of the COX enzyme like an NSAID does. Instead, it acts as a reducing agent at the peroxidase site of the enzyme.
Okay, let's break that down for the listener. What does acting as a reducing agent actually mean for the platelet?
So the COX enzyme requires a specific level of cellular oxidative stress, essentially a specific chemical state, to function properly and produce those inflammatory prostaglandins. Acetaminophen reduces that oxidative state.
I see.
Essentially starves the enzyme of the environment it needs to work. In areas of really high oxidative stress, like a severely inflamed joint, acetaminophen doesn't have much peripheral effect.
Right.
But in the highly controlled environment of a laboratory blood sample, or early on in the subtle inflammatory cascade of a PRP injection, acetaminophen alters the chemical state just enough to functionally inhibit prostaglandin synthesis, and that ends up suppressing platelet aggregation.
Just to add another whole layer of complexity to this, that same 2022 systematic review found that COX-2 selective NSAIDs, like celecoxib or Celebrex, did not show a significant decrease in platelet aggregation.
Which is so counterintuitive based on how we usually categorize these drugs.
Right. So clinics are routinely handing out Tylenol as the safe alternative, but the lab data says it alters the oxidative state and sabotages the platelets. Meanwhile, a prescription NSAID like Celebrex might actually leave the platelets alone because it only targets COX-2, completely bypassing the KOX1 enzyme that makes the platelets sticky.
Yeah.
So why is there such a massive disconnect between what the clinics are telling patients to take and what the lab researchers are actually finding?
Honestly, you are looking at the realities of practicing medicine in the real world. Clinicians are constantly balancing perfect, pristine science with actual patient compliance.
Right. It's about managing human behavior.
Exactly. Imagine you are the physician. You have a patient who is experiencing significant discomfort after a procedure. If you tell them you can't take anything at all, you just have to tough it out.
They're going to break.
Right. Human nature dictates that the patient is likely going to crack on day 2, open their medicine cabinet, and grab the strongest thing they have, which is usually a high-dose ibuprofen.
And we know definitively that ibuprofen will shut the whole peripheral system down.
Exactly. Acetaminophen might cause a 22% drop in aggregation by altering that peroxidase site, but ibuprofen will basically paralyze the entire workforce.
So it's harm reduction.
While strict purists, like the clinic in San Jose we mentioned earlier, openly suggest holding both NSAIDs and acetaminophen if the patient can tolerate it. Most clinics view acetaminophen as the lesser evil.
That makes total sense.
It's a calculated compromise. They offer a slightly suboptimal pain reliever to keep the patient comfortable, preventing them from reaching for the medication that will totally ruin the treatment.
But it is incredibly important for anyone getting this procedure to know the full truth behind that compromise so they can make an informed decision.
Completely agree.
Because the data suggests that if you want the absolute, uncompromised, 100% best possible results from your O shot, you really should try to avoid acetaminophen as well.
Yes.
So if I'm aiming for maximum tissue regeneration, what are my options if I get a headache or have localized swelling from the injection?
You really have to lean on non-medicinal interventions. For post-procedure swelling, a cold compress or an ice pack wrapped in a cloth, applied for 20 minutes at a time, is highly effective for pain management.
And no chemicals involved.
Right. It will not chemically alter your platelet function. Hydration, rest, and simply allowing your body to process the acute inflammation naturally. That is the truest way to protect the integrity of the procedure.
It really reframes the whole experience from a passive treatment into an active biological project, you know?
Yeah, that's a great way to think about it.
You aren't just getting an injection and walking away. You are initiating a month-long cellular regeneration process, and your primary job as the patient is to just stay out of your body's way while it works.
You are providing the biological environment for those growth factors to succeed.
Yeah.
It requires discipline, but when you understand the cellular mechanisms at play, it becomes so much easier to justify the temporary inconvenience of skipping a painkiller.
Absolutely. So let's look at the clear roadmap for anyone preparing for this. The O-shot relies heavily on your body's natural inflammatory healing cascade to build new blood vessels and repair tissue.
Right.
NSAIDs halt that cascade by blocking the COX enzymes that allow platelets to aggregate and signal for help. To get the absolute most out of an O-shot, the golden rule is to clear all NSAIDs from your system for a full 14 days prior to your appointment and maintain that ban for 14 days after.
14 and 14.
Yep. And if you can brave it, the latest science suggests you should skip the acetaminophen too, relying on ice and rest to manage any discomfort.
You are protecting a highly sophisticated biological process. You want every single platelet firing at maximum capacity.
We've spent this entire deep dive looking at how a single class of common medication interacts with one specific specialized medical procedure.
Yeah.
But it really makes you step back and look at the bigger picture of our everyday health habits. I mean, if a simple over-the-counter pill that we swallow without a second thought is powerful enough to completely derail a sophisticated cellular regeneration treatment.
Pretty wild to think about.
What other natural healing processes in our bodies are we unknowingly shutting down every single time we reach into the medicine cabinet for a quick fix?
It certainly challenges the automatic reflex to chemically suppress every minor ache and pain. Sometimes the body knows exactly what it's doing.
We just have to let it work.